بسم الله الرحمن الرحيم. هنتكلم النهارده عن muscle relaxants. Muscle relaxants, what they are used for. They are used to facilitate intubation of trachea, facilitate mechanical ventilation, optimize surgical working condition. The normal physiology of neuromuscular junction include nerve terminal, motor end plate of a muscle, synaptic cleft, and the process include nerve stimulation, release of acetylcholine at the synaptic cleft, and postsynaptic events. This is a neuromuscular junction which include a presynaptic terminal membrane and with the storage vesicle which include acetylcholine and other chemicals, and this synaptic cleft and with the motor end plate which include nicotinic-cholinergic receptors as the muscle fiber. So when a nerve stimulation occurs, the vesicles will release its chemicals in the synaptic cleft to have its action on the motor end plate nicotinic-cholinergic receptors on the muscle fibers. Binding of acetylcholine to receptors on the muscle end plate will activate ion channel, and sodium calcium will be inside into the cell and potassium will be outside of the cell, and action potential will be initiated and muscle fiber contraction occur. Muscle relaxant has two groups: depolarizing muscle relaxant, succinylcholine, non-depolarizing muscle relaxant, which is divided according to its duration of action into short-acting, intermediate-acting, and long-acting drugs. We will begin with depolarizing muscle relaxant, which includes succinylcholine or succinylcholine. The mechanism of action of succinylcholine, it physically resembles acetylcholine, act as acetylcholine receptor agonist. It's not metabolized locally at neuromuscular junction, metabolized by pseudocholinesterase in plasma. Depolarizing action persists more than acetylcholine, with continuous end plate depolarization causes muscle relaxation. It passes into two phases. Phase 1, neuromuscular blockade due to interaction between succinylcholine molecule and the receptor, nicotinic receptors. And phase 2, neuromuscular blockade due to continuous stimulation. It resembles blockade produced by non-depolarizing muscle relaxant, and it occurs when we use succinylcholine as infusion or in dose more than 3 to 5 mg per kg. The clinical use of succinylcholine is most often used to facilitate intubation, and the intubating dose of succinylcholine from 1 to 1.5 mg per kg. Onset of action is very short, from 30 to 60 seconds, with duration from 5 to 10 minutes. The most frequent clinical indication: tracheal intubation, short procedures, obstetric surgery, electroconvulsive therapy, relief of severe laryngeal spasm. Contraindication of its use include myotonia congenita or dystrophica, history of prolonged apnea with the same drug, conditions associated with excessive release of potassium. Side effects of its use: cardiovascular effect, muscle fasciculation, postoperative muscle pain, increased intraocular pressure, increased intragastric pressure, increased intracranial pressure, hyperkalemia, malignant hyperthermia, which is lethal, and from the most important complications which occur with succinylcholine, malignant hyperthermia, prolonged apnea, and it's called succinylcholine apnea, increased histamine release, and anaphylaxis. Non-depolarizing muscle relaxant, as we said before, they are divided according to its action into short-acting, intermediate-acting, and long-acting. The mechanism of action, it competes with acetylcholine at binding site, don't depolarize the motor end plate, act as a competitive antagonist, excessive concentration causing channel blockade, act at presynaptic site, prevent movement of acetylcholine to release site. Indication of its use: tracheal intubation during general anesthesia, allow light levels of general anesthesia, and in ICU. Is divided into long-acting as pancuronium, intermediate-acting including galamine, vicuronium, rocuronium, atracurium, and cis-atracurium, short-acting mivacurium. Route of elimination of non-depolarizing muscle relaxant: long-acting by kidney and liver, intermediate-acting including kidney, vicuronium and rocuronium through kidney and liver, atracurium and cisatracurium through Hoffman degradation, short-acting drugs mivacurium by plasma cholinesterase. Long-acting non-depolarizing muscle relaxant pancuronium, it's aminosteroid compound, onset from 3 to 5 minutes, duration from 60 to 90 minutes, intubating dose from 0.08 to 0.12 mg per kg, elimination mainly by kidney 85%, liver 15%, side effects include hypertension, tachycardia, and dysarrhythmia. Intermediate acting non-depolarizing muscle relaxant include Galamine, duration 30 minutes, onset of action from 2 to 3 minutes, dose 2 mg per kg. It has a vagolytic effect, so it's no longer popular. It's totally eliminated by kidney and changed, and it passed placental barrier. Rocuronium, analog of pancuronium, much less vagolytic effect and shorter duration than pancuronium, onset from 3 to 5 minutes, duration 20 to 35 minutes, intubating dose from 0.08 to 0.12 mg per kg, elimination 40% by kidney and 60% by liver. Atracurium is metabolized by ester hydrolysis and Hoffman elimination, onset from 3 to 5 minutes, duration from 25 to 35 minutes, intubating dose 0.5 mg per kg, side effects, histamine release causing hypotension, tachycardia, and bronchospasm. Cisatracurium, it's an isomer of atracurium, metabolized by Hoffman elimination, onset from 3 to 5 minutes, duration from 20 to 35 minutes, intubating dose from 0.1 to 0.2 mg per kg. It has minimal cardiovascular side effect and much less adenosine produced. Rocuronium, it's analog of Rocuronium, rapid onset 1 to 2 minutes, duration from 20 to 35 minutes, onset of action similar to that of succinylcholine, intubating dose 0.6 mg per kg, and elimination primarily by liver, slightly by mivacurium, only non-depolarizer with shorter duration, onset from 2 to 3 minutes, duration from 12 to 20 minutes, disadvantage histamine release and hypertension, and it hydrolyzed by plasma cholinesterase. Alteration of responses of the muscle relaxant, it's affected by temperature, acid-base balance, electrolyte abnormality, age, concurrent disease, and drug interaction. Concurrent disease as neurological disease, muscular disease as myasthenia gravis and myasthenic syndrome, liver diseases, and kidney disease. Drug interaction with inhalational agent, intravenous anesthetic, local anesthetic, neuromuscular blocking drugs, antibiotics, anticonvulsants, and magnesium. What are the purposes of monitoring of neuromuscular function? For administration of additional relaxant as indicated and demonstrate recovery. And how to monitor by clinical signs or use of nervous stimulator. Clinical signs of recovery include sustained head lift for 5 seconds. This is the best clinical sign. Lift the leg, ability to generate negative inspiratory pressure at least 25 centimeter water, able to swallow and maintain a patent airway, other crude tests like tongue protrusion, arm lift, hand grip strength. Reversal of block. Drugs used for reversal of block are cholinesterase inhibitors. Reversal should be given only after some evidence of spontaneous recovery appear. Muscarinic side effects like bradycardia and bronchospasm occur, so to prevent these muscarinic effects, some anticholinergic like atropine or glycolate is to be given with cholinesterase inhibitor. Mechanism of action: it inactivates the enzyme acetylcholinesterase, which is responsible for breakdown of acetylcholine, thus increasing the amount of acetylcholine available for competition with non-depolarizing agent, thereby establishing neuromuscular transmission. Anticonvulsants used for reversal are neostigmine, pyridostigmine, idurfonium, and physostigmine. Neostigmine, anticholinergic preferred with it is glycopyrrolate because both have the same onset of action. They are both slow acting. Onset from 3 to 5 minutes. Elimination half-life 77 minutes. Dose from 0.04 to 0.07 mg per kg. Idurfonium, Anticholinergic preferred with it is atropine, both fast-acting. Pyridostigmine is a preferred drug for renal failure patients in whom a prolonged stay of muscle relaxant is expected. Atropine, the dose of atropine is from 0.01 to 0.02 mg per kg. Sugammadex is a new reversal agent. 4-motor soluble complex with rocuronium has good safety profile. Its dose is 2 mg per kg and it's useful in treatment of overdose. Causes of inadequate reversal: inadequate dose of nystigmine, renal failure, hepatic failure, hypothermia, electrolyte abnormalities as hypokalemia or hypocalcemia, associated neuromuscular diseases, acid-base abnormalities, especially acidosis. Choice of muscle relaxant. For rapid tracheal intubation, use succinylcholine or rocuronium. For hemodynamic stability as heart disease, use rocuronium, cis-atracurium. In renal or hepatic dysfunction, use atracurium, cis-atracurium, or mivacurium. In myasthenia gravis, better avoid muscle relaxant, but if essential, use 1/10 dose of atracuriums and titrate. In asthmatic patients, if possible, avoid use of histamine-releasing drugs as succinylcholine, atracurium, or mivacurium. Clinical criteria of adequate recovery from the effect of muscle relaxant, as we said before: return of normal tidal volume, ability to open eyes and keep them open, sustained tongue protrusion, head lift for 5 seconds, sustained firm hand grip, effective cough, return of full muscle activity by nerve stimulation. Clinical signs of incomplete reversal of muscle relaxant: shallow respiration and cyanosis, jerky movement of extremities and trunk, diplopia, a restless, frightened patient who says that he or she cannot breathe, inability to raise head or protrude tongue, the use of nerve stimulator. Management of this condition should include assisted ventilation with oxygen, more nystigmine up to 5 mg, tracheal intubation with mechanical ventilation. Try to find the cause of this prolonged effect of muscle relaxant. Thank you.